It will let them finish whatever. They'll still like.
Then we went over to here and did that.
I was helping someone with the phone. I let them finish.
You say lunch?
Oh, no. It's probably find somebody. Yeah. So I'll be well, I was here twice.
Oh, you were?
So
Okay.
so I was PEB director from 98 to 2002. And I went back to Medicaid, and then the agencies joined together and Medicaid director here.
Okay.
So, all right, well, we're going to go ahead and get started. So I'm going to call this meeting to order.
You turn on your mic also.
Oh, and turn on my mic. It's not turning on. It's just oh, I think I'm pushing the wrong button. All right. It looks like the right button. Well, it's like I have three choices. Anyway, good morning and welcome. I just want to welcome you all to our April PEB board meeting. Again, just reminding folks our meetings will continue to be hybrid, and healthcare authority staff will be on site, and board members and other attendees have the option of attending on site or via Zoom. So for members of the public attending via Zoom, our opening slide has information about how attendees can turn on closed captioning subtitles. And also public meeting attendees will only be able to activate their audio and or video during the public comment period at the end of the meeting. At that time, participants will need to raise their virtual hand, and only after being recognized by HCA staff will the participants see the ability to turn on their audio video options. So right now, I want to do a roll call to identify the board members with us today. So Michaela Dolman, present. Elliot Weinstein, present. Harry Bashi, see.
Present.
Tom McRobert,
Present.
Tom Comerford.
John Comerford, present.
John, okay, I'm sorry. Sorry about that. Sharon Lang, I think is attending virtually.
And she'll be late. If she attends, the staff will alert me and then I'll announce that she's on.
Okay, and Kurt Spiegel, also
present.
Thank you. And then also with us today is Mike Tennant from the AG's office.
Present. Thank you.
And I'm Marianne Lindeblad, Healthcare Authority Interim Director and Board Chair. With board members attending both in person and virtually, it would be helpful for the board to hold their questions until each presentation is done, when the presenter pauses and asks if there are questions. Board members attending virtually, we will also watch in case you use Zoom's raise your hand feature to indicate you have a question. There are no resolutions scheduled for action in today's meeting. The public will be able to provide general comments at the end of the meeting during the public comment period. Also, as a reminder, if the public has questions during a staff presentation, the presenter's contact information is included at the end of their presentation. The public is welcome to email presenters during the meeting to capture your question for a response after the meeting. And then I'm going to turn it over to Dave, who will now provide us an overview of today's agenda.
Good morning, Chair Blatt, members of the board. Today, we will primarily bring you up to speed on where things are from the legislative session, both from a bills and budget standpoint. We do have a resolution to introduce to you. It's not for action today, but remember we have a strong tradition of introduce at one meeting, ask for action in the subsequent meetings. Early spring is eligibility enrollment policy resolution time, and so we do have one resolution I'm bringing to you for teeing up for consideration and action at the May board meeting. We'll also go into an annual rulemaking briefing that talks about the agency's annual process for PEB and SEB rulemaking processes, and bring you up to speed on things that are going to be cleaned up and worked on and revised with the rules, some of which don't require your action, but it's revised as the overall scope of that rulemaking. Where this season we're having a standard update on benefits 24/7 and how stabilization is going. So we'll have our CIO back with us. And then we will have, as we transition into late spring, we begin the renewal process. So we have an overview for you on the medical plan renewal process that ultimately culminates in rates and premiums that we ask the board to adopt in July. Two other housekeeping things that I wanted to mention. This one, first meeting we've had since it happened, so I just wanted to update you on it, that the number of concerns that were raised about the potential network disruption between regions, Providence, Swedish, PACMed, all of that came to a conclusion in a positive new 2-year network agreement between the entities. And so there was actually no disruption for that, for the UMP network on April 1st. It was, I think an agreement was reached the Friday before, but there were a lot of announcements that could go out till the Monday of. So we have dusted off our communications as it deals with that. We will probably, it may not be the last time we have any of that happen this year. There are some bills in the legislature that kind of touch on this topic too. Kate will update on those, but the good news is an agreement was reached, and just like many past disputes, an agreement is ultimately reached. Last reminder, if you need the restrooms, go down the hall, see elevators, look to your left. We have an emergency, we walk purposefully across the street into the visitor parking lot.
Thanks, Dave. Not at all?
Yep.
Thank you. So let's go ahead and today we'll be voting on the minutes from our last meeting in March, and the meeting minutes are behind tab 3. Are there any comments from the board? Okay. Do I have a motion to approve the minutes as written? It's been moved and seconded. I'll give a second. Who will give the second?
I'll give a second.
Okay, moved and seconded. So all those in favor say aye. Aye.
Aye.
Any opposed? All right. So the March 13th, 2025 minutes are approved as written. Thank you. So next, Dave is going to go ahead and bring back some information regarding a question that we had brought up at the March meeting. So Dave's material is behind tab 4.
Good morning, everyone again. We like to integrate information where we can, where presentation makes sense, but otherwise I do clean up at the beginning of the meetings for some miscellaneous questions, if you will. So there were a couple of questions from the pharmacy presentation, or Luke's component of the presentation at the March board meeting. And the real question here on the slide was, did the Medicare drug price negotiations apply only to standalone Medicare Part D plans, or did they include standalone Medicare Part D plans, or was it only Medicare Advantage Part D plans? And the answer is on the next slide, drum roll. Since all Part D plans are Medicare Part D plans, they're all subject to Medicare rules. And so the Medicare drug negotiation efforts that were part of the Inflation Reduction Act, that we're now into year 2 of that process, they do apply to both types of plans. And so a prescription drug plan that is not affiliated with Medicare does not need to cover these drugs, but all Part D plans are Medicare Part D plans and therefore subject to Medicare rules. And then the next slide is just a quote to be able to give you some more citations. I'm not going to read through this, but this is from CMS's website about the Medicare negotiation drug price. And if people want to learn even more about that process, the full link is at the bottom of the slide for you to be able to go as well. So that was just the miscellaneous. Does this apply to standalone or the Medicare apply to all Medicare Part D plans? The answer is yes. So that's just the one piece that didn't fit nicely anywhere else. I wanted to wrap up from last. Any questions? John?
David, with everything that's going on in Washington, and particularly the speed which is going on, do we have any fears that there are going to be changes this program year that we're going to have to deal with or address?
I don't know that I would use the word fears. I think you're right. There's a lot of change that happens very quickly right now from the federal government. And it does not seem that anything is immune from potential change. And as we learn any concrete things, we will definitely bring it back to the board. There are certainly, if I had a crystal ball to be able to predict the federal government now, I think I'd be able to retire. But I don't think anything is immune from change. And we just have to wait and see and then discuss the concrete changes that are made if they are made.
The reason I ask is I noticed they withdrew some medications from this year's allocation of new meds to be cost controlled.
Yep.
And that has not been publicized terribly well. But I'm wondering, does that affect us?
Well, by definition, the entire drug negotiation process under the IRA, Inflation Reduction Act, is something that impacts the UMP Medicare formulary as well as all of the other Part D formularies that are part of the Kaiser plans in our Medicare portfolio. And so if there are drugs that are removed from negotiation in the future, then that is, we also will, our plans will also not benefit from any reduced pricing that could have been negotiated in that part. So the short answer is yes, it would impact our plan by not having those, us be able to benefit from that leverage federal price negotiation.
Thanks.
Elliot.
And the same would hold true for tariffs, I assume.
Well, I think there's there's definitely conversations and news starting to come out about like the potential for tariffs, if and or when they go into place, exactly where they go into place in the world and the effects of pharmaceuticals. And so there's certainly the possibility there as well. Yep.
So coming back to, John. I've been away for a while. This is kind of a new experience.
Back to civilization.
So coming back to John's question, so I looked at the proposed drugs that would be negotiated for 2026 and then 2027 and then 2028. And so I remember that for 2026, the first one at the top of that list was Eliquis. So that list of drugs is what John's referring to. And some of those drugs that were on that list have been removed from it.
For next year, I
For
think.
next, for 2026.
27.
Oh,
27.
Yeah.
Okay.
I will
think so.
have Luke and
Yeah.
Brian and team put something together and maybe they'll be do April cleanup or May cleanup for April. So I'll have them put together something about any changes that were already made in that vein.
Thank you.
Any other questions?
All right. Let's go on to our legislative update and budget update. So, Kate Walker from Policy Rules and Compliance, from the Employees and Retirement Benefit Division, and Tanya Poole, another individual from our Employees and Retirement Benefits Division, our finance manager, and they will be bringing back the latest from the legislative session and some budget updates. And Kate's and Tanya's material is behind tab 5.
Good morning, Chair and members of the board. Happy to be here with you again, provide you a brief update. I'm gonna try and keep this one as brief as possible, which is not normally my MO, but we'll get about here. Next slide, please. Just our numbers. We've hit 200 bills that we've done this year so far, so a lot of work. So I'm going to take that time just as a reminder to myself to thank all of the bill analysts and everyone who works on our team to get this work done. That simple chart represents probably thousands of hours so far where we're at in session. So big props to all of them who are listening and otherwise engaged and helping us keep this work flowing well. And also on the fiscal note side, you can see we had over 80 fiscal notes for the year, if not more. I think we got a few more this week. So also shout out to Tanya's team. Next slide. A little out of date, but given that we had a cutoff on Tuesday for the opposite chamber, time flies at this point of the year, but we are still tracking several bills that are of high priority to the division that are making their way through the process, and so far looking like the runway is fairly clear for them to pass this session. So as that wraps up, as the regular day of session wraps up on the 27th, which we're just a little bit over 2 weeks from that. When we get to cross the finish line, we'll make sure we'll be presenting on what bills made it through the entire process. But with that, we'll go into what legislation are still moving forward. Our two pieces of agency request legislation that we've talked about before are still moving forward. That would be Senate Bill 5083, our affordability bill, and Senate Bill 5478, expanding this board's authority to offer optional benefits to employees. Both of those pieces of legislation are continuing to move forward and have made it through the cutoff as of Tuesday. Next slide, please. On the current legislation that we're tracking, House Bill 1069 is still moving forward, which would allow for collective bargaining over contributions for certain supplemental retirement benefits. We're tracking that, and there's discussion on that happening currently. As David mentioned as well, we are Continuing to follow 5579 concerning those public statements that are sent out within 30 days of contracts possibly terminating between providers and carriers. That legislation put some additional requirements on how those notices can be sent out, and certain legal requirements that show good faith efforts have been made on negotiations, and they're not just trying to use it to leverage the contracting process. So we're continuing to track that. We're also following a couple of pieces of new legislation that came out that are part of budget. They're referred to as necessary to implement the budget. It'd be Senate Bill 5793 and what's not listed here, which is 5807, which just came out in the last few days. They're very similar bills. 5793 and 5807 both remove the Smart Health Program and the Wellness Incentive from the PEB and PEB programs. The difference being that 5793 had some additional restrictions on bargaining that it placed. So 5807 is essentially a slimmed down version of 5793, both of which remove the Smart Health and the Wellness Incentive. It does not impact the entirety of the wellness program for the program, though. I just want to make sure that that's noted. There are certain elements of the wellness program for the division, for both PEB and SEB, that are not removed by this legislation. Those would include things like the smoking cessation program, the diabetes management program, that are part of the wellness program overall, but are not removed with these two pieces of legislation. It's strictly focused on the wellness incentive and the smart health applications.
I'll just add to this, for both bills, they both are the same for Smart Health. They retire the Smart Health program effective January of 2028. And part of that is to honor the current collective bargaining agreements that are funded in both chambers' proposed operating budgets. And so that takes us through essentially having the portal and the incentive for everyone that's eligible. Through the end of 2027, the last distribution of incentives would be January 2028, and then both the incentive and the portal, the Smart Health portal, would retire. So that's the Senate proposal, and that's the same in both of these bills. As Kate said, the additional part of 5793 is a proposed suspension of healthcare bargaining, the healthcare bargaining tables for both PEB and SEB for the next biennium. Instead, would have the legislature directly appropriate and allocate this employer contribution for the programs. So.
Moving on, current legislation regarding providers, the House Bill 1114 Respiratory Care Compact, which would have Washington participate in the multi-state compact regarding recognizing licensure for respiratory therapists, continuing to move forward. However, as of Tuesday, House Bill 1430 did not make it out of the Ways and Means Committee, and so 1430, for all intents and purposes, is now dead for the remainder of the session. It will, like every bill that's not made it out of a committee this year, they'll be revived by rule for the remainder for next session, which is part of the full legislative cycle. So we'll see them again, but 1430 did not make it out of the committee on Tuesday. Next slide, please. Senate Bill 5498 concerning contraceptive coverage. Just very simply, it allows for a longer period of a prescription to be prescribed at the onset for certain contraceptive coverages, as opposed to having to have a refill that allows for a full year contraceptive coverage. So it just expands fairly minor but significant at the same time for allowing that initial prescription to have a full year's coverage. House Bill 1669, coverage for prosthetic limbs and custom orthotic braces, is continuing to move forward. However, in a subsequent revision of it, the PEB and SEB programs have been excluded from participating in the requirements for the expanded coverage for prosthetics and custom orthotic braces.
I see some puzzled looks, so I'm going to chime in on something related to that. I remember saying this at the subboard meeting last week. So a lot of times historically, benefits bills in the legislature have often started with the PEB and SEB programs and then potentially in subsequent years expanded out to the rest of the commercial market. This year, we've seen a couple of bills, and the only one that I believe that is still active in the legislative process that actually do reverse, starting with the commercial market and then maybe one day impacting the PEB and SEB program. And a significant piece of that is if the PEB and SEB programs aren't implicated, then the fiscal note is essentially zero because there are no state costs to impacting the general commercial market. But there is a state cost if the benefit is made into these programs. And so if you go back to our January retreat, it's one of the reasons that we brought the budget director from OFM to highlight the multi-billion-dollar challenge. And there, every piece of it helps. And there are a lot of things that are hard to quickly adjust within these programs. But one thing that the legislature can do is minimize additional expenses by limiting expanded benefits within the portfolio. So I'm not sure if this trend will continue or not, but I think it's a manifestation of the budget challenges, and knowing that PEB and SEB being carved out means no state cost essentially from at least these programs.
Any questions there?
Yeah, Kate, help me understand process-wise. Say we take a bill that didn't make it out of committee. Is it still possible through amendment process that those words that didn't make it out show up in an amendment to anything that still is a carry, right?
Yes. So until it passes through both houses, and then if there are revisions made in the second chamber, then it has to be approved. There's consensus that has to be made from the previous chamber. And then in that instance, that would go to the governor once it's had consensus from both chambers.
So theoretically, this 27th or thereabout date at the end of the session. Yes. Okay. Thanks.
On the pharmacy side, both House Bill 1186, which expands some of the medication prescribing authority for hospitals and healthcare entities, is still moving forward, as well as House Bill 1971, which again increases the amounts for prescription for hormone therapies. With that, I'll see if there's any other questions. Otherwise, I'll turn it over to Tanya.
Yeah, Senate Bill 5083, ensuring access to primary care, behavioral health, and affordable health hospital services. If I remember correctly, about 2 years ago, we had a presentation on diversity and the forbidden words, diversity, equity, and inclusion. Part of that conversation about equity was the lack of access to services particularly in rural areas, and that people were leaving those rural areas, which was inhibiting their ability to get access to those services. So is this kind of attempting to address that in some particular way, in fashion?
I think the answer is yes. I think there is an aspect of this that does address that. But in my short answer, I'll turn it over to Dave.
I was gonna say, I'll fully agree. So I think Kate said that, well, generally, yes, but there are several components to this legislation. So it is definitely multifaceted. Part of it is capping reimbursement rates for the largest and health systems and facilities across the state, having a singular cap on reimbursement rates. It also is investing in behavioral health services by raising the floor at which those reimbursements can happen. So, there is an investment side of the equation into behavioral health services, hopefully to promote access. And then there is a component that requires as long as they're, I'm going to say the wrong buzzwords, there has to be, the facilities can't reject a contract. I'm going to say good faith, but I think that's a different part of statute. But there has to be like a true, valid, good faith contract offer. Though I'm positive I don't have the exact statutory words now because I think I'm thinking of Cascade Care instead of this bill. But there is some sort of legitimate comprehensive contract that has, as long as that offer is made, it can't be rejected, which also gets to preventing network disputes within the Uniform Medical Plan and the Kaiser plans, the Kaiser PPO plans that are in some programs. So there is this, it's multifaceted, going to network disruption impacts, as well as capping reimbursement rates prospectively, and also investing in behavioral services. Is there another piece? Tanya pulled up the right word.
Good faith.
Oh, it is good faith. Okay, a good faith offer is made. I did remember that. Anything else, Katie, you think we should add? Is that helpful, Tom?
So in capping reimbursement rates, does that affect who specifically would be the most affected by that? Would individual doctors be affected, or would this be more generic to the general, like hospitals or that piece work? Because I know that's an issue. Reimbursement has become a big issue.
So the bill is primarily about the large systems of the state. So I don't want to really go into naming any, but the largest facilities and the largest hospital systems. The ones that classically might be those network disputes that you end up reading about and that we talk about on a regular basis here. It is not every provider in the state, but if they have the affiliation or integrated with one of those large hospital systems or facilities, they could be impacted. But if there's not some sort of affiliation or direct relationship with that facility or hospital system, it's not every provider throughout all four versions.
Good morning, Chair, members of the board. For the record, my name is Tanya Jewell. I work in PEBB. Might be a new acronym for some of you here. We used to be the Financial Services Division, but we now have a new acronym, which stands for the Finance Service and Healthcare Purchasing Administration. And yes, I had to look at my slide to say that in the right order. All right, so I'm here for a part 3 of hopefully only a 4-part series on the budget. Hoping we're done after this next one, but this is really kind of to bridge, we talked about what the agency requested in decision packages, what Governor Inslee funded in his version of the budget back in December. We talked about what Governor Ferguson recommended as far as some budget reduction scenarios. And here I'm going to talk about what we've seen in the House and the Senate proposed budgets. And then hopefully my next presentation will be on a final conference budget. We're going to do a quick little pit stop on our supplemental budget. A lot of these should be fairly straightforward because we have very much alignment between Governor Inslee's budget in December, as well as the House and the Senate proposed budget for all of our decisions. So I'll kind of fly through these. So for our supplemental budget, as a reminder, in a long session, we have to kind of true up the rest of this biennium, and we do that through a supplemental budget. And then we move into the biennial requests also. So for our supplemental budget, both our third-party administrator spending authority as well as our contract increase decision packages were funded in both the House and the Senate at the same amount. As a reminder, our TPA spending authority is just our third-party administrator costs that we pay to Regents, Moda, and Delta Dental to administer our self-insured products. This increase comes every year back to the board because we're really just truing up with the enrollment of our self-insured products. The last one, our contract increases, is again a true up of our actuarial work order budget. The demands of our actuaries with the real complex work we've been doing has resulted in us needing a little bit more. And over the last 10 years, we haven't even had an increase to that budget. So this is really the first one we've seen in a really long time.
Tanya, just as a reminder for everyone, fiscal year 25 ends June 30th, the one that's coming up in 90 days. And then to tie back to Tanya's presentation from last board meeting, this isn't money that needs to be appropriated from the general fund. This is spending authority from the big central box into some of the lower left boxes that were in that multicolored chart. So that's why it says spending authority. It's not a new appropriation, if you will. It's new drawdown authority from the big claims fund.
It's the revenue we've already collected is there. We just need the authority to spend the money is what this one is. So next we're going to walk through the biennial decision packages, and these will be very similar, but a larger amount because instead of covering the end of just 1 year, we're talking 2 years worth of spending. So the first two are the same exact items, but biennialized over a 24-month period. So our third-party administrator spending authority, as well as our contract increases, was funded in both the House and the Senate proposed budgets. And then really exciting for this board is the IT resources decision package. We did see this earlier on in Governor Inslee's budget, and we're really excited to see this in both the House and the Senate proposed budget, that they are prioritizing the increase of FTEs to support our benefits 24/7 system. You'll see here for PEB on the screen, we have 5.5 FTEs, but this is actually a total of 9 FTEs when you combine the PEB and the SEB decision packages together and the funding. It's a combination of our IT staff, some payroll staff, and some staff within Dave's division, but all supporting the work related to kind of the benefits 24/7 and enrollment process. On the next slide are some of our benefit enhancements that we requested. The first one being doulas. So currently doulas are not a reimbursable provider type within the PEB and SEB Uniform Medical Plan offerings. So funding was requested to be able to offer reimbursement for doula coverage. We still have some operational challenges we're working through here to see if regions can operationalize doula coverage in the next plan year. However, if we can pull that off, the funding is here and available for us to do that. The next one up are a couple of dental options that were requested in our decision package. And this was an enhancement for removing the deductible for children under the age of 15, and this is in the Uniform Dental Plan only. So currently children have a $50 deductible, and this would remove that deductible, kind of removing some barriers for children getting into dental. And then it's also funding to increase the TMJ coverage. Currently, there's a pretty small TMJ annual and lifetime benefit, and this would increase that slightly. One small piece of note here, I know a lot of our conversation has been around budget reductions, and we have 2 enhancements here on the page. I just want to note that between these 2 items over the 24-month period, this is not a significant amount, enough to increase the funding rate. So while someone might look at this and say, yeah, it's $700,000, it is, but it's not enough that the legislature has to increase our funding to the program to cover these costs. So it kind of comes out within our current spending.
And this was kind of a purposeful strategy with the decision packages. And again, going back to January and highlighting the reason that we had a budget director talk about this, don't expect large, huge, big benefits unless the legislature passes a bill and directly funds it. And we focused on things that might qualify if this doesn't adjust the funding rate area to make slight adjustments. And these dental benefit enhancements are actually to bring the PEB program into alignment on these components of the Uniform Dental Plan that the SEB program was implemented this calendar year, or this calendar year. Recently, we'll just say recently, in the last 1 to 2 years. There are still a few differences between the programs for the Uniform Dental Plan, but this brings them closer into alignment.
And the last one related to decision packages is the administrative support related to Senate Bill 5083. So the bill Kate, Dave were just talking about, it does have some administrative dollars associated with it, and this would be the administrative dollars to support the actual work needed to pull off that legislation. I will note this is very small in comparison to the offset and savings that this bill would bring to the program. So transitioning from decision packages, there's a couple other items that were within both the House and the Senate proposed budgets. And that is just continuing from the Governor Inslee version of the budget, the combining of the PEB and SEB sections of the budget. This is not consolidation. This is just kind of a back end accounting budget function where we will have one program for budget and accounting purposes. All funds will stay separate. All accounting will still be separate for PEB dollars versus SEB dollars. It will just be under one administrative program in the budget. The next one is enhancing our employer paid long-term disability benefit. Currently, as part of the funding rate, the employer contribution towards the long-term disability is around $2. That $2 has had an actuarial analysis done around it with Standard, who is our vendor for our long-term disability. And it's shown that our long-term disability experience actually has been favorable for that premium level. And within that same premium level, we can enhance the benefit from $240 to $450. One thing to note here is that while we're really excited about this, I think, it's not a huge step, but given the budget, scenario we're in right now, the legislature actually could have chosen to decrease our premium and keep us at $240. So seeing that they're willing to maintain that same $2 investment is really nice. Okay.
I just want to confirm, this long-term disability is a separate benefit from the one that's offered through that ESD is administering, that's kind of like beyond state government?
Yes.
Okay.
Yeah. This is HCA PEB SEB only long-term disability through the standard.
I'll also highlight that this will be only the second time that the employer paid LTD benefit has ever been increased. The original benefit in I think it was the State Employee Insurance Board, SEIB, back in the 80s was $180. And then at some point in the late 90s or early 2000s, it increased to $240. And it has been there for the last 20 plus years. So, it's a small incremental change, but it is the second time that there will have been an increase. And, $450 will, it's a step. We've been talking about LTD every year for the last 4 to 5 years, and it's just another piece of the puzzle. It should result in a small reduction in the employee paid benefits. The way to think of it is right now, the first $240 of a benefit is paid for by the state. And then when an employee has additional supplemental coverage, they build off, they pay $241 up to whatever the salary amount is for their calculation. Now the state would pick up the first $450. Therefore, the amount that the employee pays for the buy-up, they won't have to pay the amount that's attributable to $241 to $450. So there'll be a small reduction that happens to the employee pay benefits, but I'm sure that even a couple of dollars is going to be appreciated. So we'll see those and be able to share that information with you later.
Moving on to the next slide, we're gonna kind of keep along the journey of some of the budget reduction items. We've talked about a few through kind of the retreat at what was included in the governor's budget, and then we talked about what Governor Ferguson recommended, and this is what was included in both the House and the Senate. So the long-term disability reserves, this has been included all along. Keeping along the theme of LTD, as I mentioned, our $2 premium has been able to go further, and it's been proven that that $2 can buy more. But because of that, we have been contributing to surplus because we've been basically overfunding that benefit a little bit. So something we're going to do is we're going to draw down the reserve for the employer paid reserves that are above and beyond what's required to keep in that balance, which is about $18 million that we're going to withdraw and deposit directly into the state general fund as part of contributing towards that deficit. The next one is the closure of the UMP Plus plans on December 31st, 2025. As a reminder, our current contract goes through the end of 2026. Both the House and the Senate included language that would close the UMP Plus plans at the end of the current plan year. I know there's probably some questions around this, and we haven't tackled a few, but I anticipate that if this makes it through the final conference budget, we'll bring back a more in-depth presentation about this later in the board season. The next one is the administrative reduction. We talked about how a lot of state agencies were directed to come up with an administrative reduction. If we think back to that flow, I had a little flow chart of the different various accounts. This was that bottom right only. So the House and the Senate did not increase our budget reduction for administrative cuts beyond that. So it's just that 6% reduction from our agency's administrative account. And just for context, it's a little bit over $2.5 million for the PEB program. And then the last one that was included by both the House and the Senate is the reduction of our premium stabilization reserves. We've talked a bit about the types of reserves that we keep in the PEB program. This one is specific to our PSR. Currently, we keep about 7% of our annual uniform medical plan claims in reserves. So about a year's worth, 7% of a year's worth of claims in reserves. This is just reducing that from 7% to 5%, which would have an immediate kind of one-time relief that we would free up those reserves. The legislature would be able to buy down the funding rate in that first year, and then it kind of tapers off in the out years. So over the next biennium for the PEB program, that's about $56 million that we could free up. Yeah, John.
Tanya, the reduction of the mandatory furloughs of state employees, does it come out of the administrative budget reduction?
No, I'll take that one on for Tanya. No, if there are furloughs of state employees, that is kind of centralized elsewhere in the budget, but there are collateral effects to the PEB and SEP programs. So going back, I feel like maybe we should have put the chart in. Going back to the chart, hopefully everybody remembers had the big box in the center, which is the revenue pot, and then there are all the subsidiary accounts, and we have an admin reduction in the bottom right, which is this agency's staff and building cost and equipment cost and contract costs. The other accounts, the other admin accounts that were in that lower level were about the TPA fund, third-party administrator funds that we pay to regions and VODA and Delta for UMP and the Uniform Dental Plan. If there are furloughs wouldn't have this, but if like staffing reductions happened as a result of admin cuts, there would be a smaller state footprint at the end of the day, which would mean there would be some lower number of subscribers, and those collaterally would lower the amount that we pay out of those other accounts. But we don't see within the PEB and SEP program some sort of central accounting for furloughs or overall staff
Even
reduction.
for our own staff, even for our.
Correct, even for our own staff.
So those were the items that were included in both the House and the Senate as far as reducing the budget deficit. And on the next slide, this one is new. This is a further option that was included on the agency's options list, which is the elimination of the Smart Health Portal and the incentive, which Kate briefly talked about. While both the House and the Senate included language for this, there's kind of two different approaches to how they did it. The Senate actually introduced a standalone bill, 5793, which would eliminate the wellness program and essentially in the next biennium. And then the House, while they didn't introduce a standalone bill, they included language in the operating budget bill that made the assumption within our funding that there is no smart health during the next biennium, and that we, work towards fulfilling obligations under the current collective bargaining and kind of end that program as soon as possible. So different approaches, but both essentially kind of do the same thing.
Two things to highlight. Don't forget that since we published these materials, there's another bill. So it's not just 5793, it's also 5807. So there's two versions of it. I think the takeaway point here is that the two chambers agree that the Smart Health program will go away. It's the timing of that wind down. The earliest process leads to something in the 2027 time range, and then the Senate version squarely has January 1, 2028 is the end of that road. With a wind down of the Smart Health program, there will need to be some policy considerations and changes to rules about whatever is the final year of that program. We may be bringing you things later this season to start to prepare for that, depending on what exactly happens with the budget, or a lot of that may be next year. But there will ultimately need to be some policy decisions about a wind down of the Smart Health program.
Next slide is just where the House and the Senate set the funding rates. I won't spend too much time here because there's a lot of underlying assumptions that drive these funding rates, and both in the House and the Senate took different approaches in how they wanted to take risk on the funding rates between, the first year and the second year. But I will say they are in alignment on our decision packages, funding the current collective bargaining agreement, including the reductions for our agency request legislation 5083, as well as all of the budget reduction proposals. So I think we're very clear in our marching orders from the funding of decision packages and what's in the budget bill language. And that is very much in alignment, and we'll see what happens in the final conference budget for the funding rate. The legislature has the ability to set the funding rate at whatever risk they want and whatever level they want. We do our best to live within that, and then we always, usually in the second year make refinements. So we'll see what happens in the final conference budget here.
This is the part where Tanya and I also say there is no magic number. Please do not focus on what is the right number. There is no correct number. It really is the important part that Tanya said, is like the assumptions that we know and the marching orders in the direction of what are pluses and minuses. But at the end of the day, there is no magic number. There is no specific target that must be met. So really important concept to highlight. Tom?
Yeah, I'm just curious, when I look at these two proposals between the House and the Senate, would one of those have, if, let's say the Senate's were to be adopted and not the House's, would there be a different impact because of the funding rates that they propose versus the House's? Or would they be, over the 2-year period, would they both be essentially the same?
It's kind of a combo. So there is no difference really between the House and the Senate as far as what was funded. The employer medical contribution set at 8515 was the same. The decision packages are the same. The budget reductions are the same. So all of the underlying assumptions are in alignment between the House and the Senate. What they chose to do is put different pressure on the first year versus the second year. So what you see in the Senate here is a lower number in the first year, and the House has a higher number. And that is because the House can choose, we want to be a little bit more aggressive in our funding rate in the first year and see what happens. And then we will come back in the second year and adjust. And that is totally okay. And it's totally appropriate. And it's what they do every year when making these kind of budget decisions. They have to balance to a 4-year outlook. So what they put within, the first year versus the second year does sometimes have implications into the out years. So it's really just about the risk that they want to take in that first year. And so we're very clear and comfortable with what is in the underlying assumptions. It's just how much risk they want to take on that funding rate.
The other thing we know for sure is the second year's funding rates will ultimately be different. I don't think we've ever had a year where
We had 1 year where we did not change the second year, and that's because we were in the middle of COVID and no one knew what the heck was going to happen with cost. So they chose to let it ride and not make an adjustment. But that's the only time we don't come back. And the reason is, we're looking at fiscal year 26 setting numbers right now. That is based on historical experience and historical enrollment before we've even set rates, because I won't be back to you guys until May and June saying, here's what our rates are. So they set our budget before we even procure our rates. So there's always that refinement that needs to happen in the second year to catch up with things.
absent a pandemic.
Yeah.
Please no.
All right, and then on the last slide is the Medicare explicit subsidy. Both the House and the Senate maintained the $183 maximum Medicare explicit subsidy. This is $183 or 50% of the premium, whichever is lesser. And that's maintained from the current calendar year. We will bring back a resolution to the board to adopt that Medicare explicit subsidy. Again, we don't have a final conference budget, so we will see what happens in the final conference budget, but we will bring back all the numbers. Most years, I'd say when things are in full alignment, we're pretty safe, but the session is a little different and things still can change. Any questions? Gary?
I'd like to go back to the long-term disability. I just curious. It's good news, don't get me wrong, but I think you said there was an $18 million transfer
Yes.
from, I'll say surplus, but
Yeah.
unnecessary, I guess, right above the PSR. So that's great, I guess. And then the other was that moving forward, looks like the benefit will be increased. My understanding of what I heard was maybe the dollar goes farther or the experience has been better than
Yes.
projected. So I'm kind of thinking myself, an actuarial kind of issue between the amount that can be transferred because of beyond and the amount that we can increase that this rate setting was done a few years ago. Maybe it was too high. I guess moving forward, I guess we're comfortable with our vendor standard and our actuaries that, we're not going to come back in a couple of years and say, well, we probably shouldn't have given up $18 million. Didn't have really the money to raise the benefit. I hope that makes sense.
It does, and that was one of our concerns too, when we were very clear when we worked with the standard and their actuarial team on this, that this had to be sustainable because we cannot go back to the legislature in 3 years and say, oops, we need to increase our premium. And that was something Dave and I were very, very conscious of. And so they did confirm to us that, in fact, that $2.10 premium can go indefinitely, I guess, barring any crazy experience that happens. But
I think actuaries, when they say the word definite, they mean like 30 years.
Yeah.
For the record.
Yes.
They don't really mean indefinite,
No.
maybe a couple decades. But yes, Harry, I mean, we even did an analysis of like, you know, the decision has been made to take those funds and put them in the general fund. But there was an alternative analysis of what if those funds were reinvested? Could you go even further than 450? And of course you could, but the decision was, given our environment, that the funds needed to be moved over and we would, you know, and then $2.10 could go to $450. I'll say that the number of times that the benefit has changed, the employer benefit, I said it's gone from 180 to 240 and now 450 would be this answer. The $2.10 is the same number that was negotiated decades ago. So that number has never, as far as I know, has never been adjusted. It is,
as long as I've been here, it has not.
well,
changed.
it's yeah, and if we even go back to some of the original contracts, it's been the same $2.10 for a very long time. And so it's just that the experience of the program is so long and deep that it's the you know, there's just this fundamental claim shift or experience shift from the 80s and 90s that it's able to support a wider benefit.
Yeah, thanks, that's a great answer. And I guess the cynic in me would say, well, maybe when the level was 240 and before we had the the new opt-in or opt-out, whatever it was a couple of years ago, that folks looked at this, I can't afford not to work. So I'm not gonna, the benefit's there, but I just can't afford to not work. Thank you very much.
Any other questions?
We left plenty of time for questions, because there might be questions.
I'll be back there if there are, so. Noodle on
We can
that.
catch them later
Yeah.
if necessary.
Thank you.
So right now we have time set aside for a break. Do folks want a break or just to go ahead? Want a break? Okay, we will take a break. That answer. That's all right. Well, let's get back together and Stella Ng is going to give us an update. She's our policy and rules coordinator in the ERP division and is going to introduce a policy resolution to us today regarding PEB program retiree coverage for consideration at our next meeting. And no action is scheduled for this today. Thank you, Stella.
Thank you. Good morning, Chairman, but members of the board. My name is Ellen, Policy and Rules Coordinator with the ERP Division. Next slide, please. This slide and the next slide are included in the presentation, so we will have them available for the policy we will discuss. Please. We have one policy resolution to reintroduce. This policy resolution is a follow-up on last year's policy resolution, PEB 2024-11, that addresses PEB retiree insurance coverage when the subscriber becomes eligible for PEB or SEP benefits. Next slide, please. For background information, the original automatic deferral policy was adopted by the board in 2022 to memorialize a PEB program's practice when a subscriber becomes eligible for the PEB benefits. The subscriber's PEB retiree insurance coverage will be automatically deferred. This resolution aligns with federal Medicare rules that require employers to offer employees over the age of 65 the same benefits under the plan and the same conditions as any other employee under age 65. The board then adopted resolution PEB 2024-11 last year to include SEP benefits. So the PEB program's practice of automatic deferral is uniformly applied to subscribers who become eligible for the employer contribution for either PEB or SEP benefits. Next slide, please. We're bringing to the board the proposed resolution PEB 2025-02 to address situations when a subscriber's dependent enrolled in PEB retiree insurance coverage and becomes eligible for the employer contribution toward PEB or SEP benefits. This proposed resolution would allow the PEB program to automatically disenroll the dependent from PEB retiree insurance coverage so that they can enroll in PEB or SEP benefits. And we recommend this policy resolution because this aligns with existing PEB and SEP rules, as well as federal Medicare rules where the employee or school employee cannot waive PEB or SEP medical and stay enrolled in PEB retiree insurance coverage. And the proposed resolution reads, proposed resolution PEB 2025-02, PEB retiree insurance coverage when the subscriber's dependent becomes eligible. When a subscriber's dependent becomes eligible for the employer contribution toward PEB or SEP benefits, the subscriber's dependent will be auto disenrolled from PEB retiree insurance coverage. And I do have an example to illustrate this proposed policy resolution. So the example, Dan is a retiree and is enrolled in a PEB Medicare plan. His spouse, Susan, is a substitute teacher and enrolled in Dan's PEB Medicare plan as his dependent. She meets 630 work hours in December 2025 and becomes eligible for the employer contribution toward SEP benefits. She cannot waive SEP medical to stay enrolled in PEB retiree insurance coverage. When will Susan's PEB Medicare plan end? Susan will be auto disenrolled from the PEB Medicare plan on December 31st, 2025, and she will be enrolled in a SEP medical plan effective January 1st, 2026.
So this policy, regardless of what month somebody becomes eligible, would be done in a way to dovetail so there's no gap in coverage. Just didn't want people to look at the end of the calendar year and somehow think there's something special about December to January. That's always dovetailing to make sure that they're not coverage yet.
And I think it's probably specifically around this example, like a substitute. The school year is different than the calendar year, and like sometimes you can get a bunch of hours and then the following year like not get any. So is the rule written in a way to where they can get pulled back too if they don't get the adequate hours?
If they don't get adequate hours and then they will become eligible for SEP benefits, and they will be disenrolled from SEP benefits, and the employee will have the opportunity to re-enroll in PEB retiree insurance coverage. And then in this example, it will be through Dan's coverage, so that will be a special open enrollment for Susan to re-enroll in Dan's coverage.
So to put a finer point on it, Kyla, in this example where Susan had benefits under the SEP program starting in January 2026, the funding year essentially for benefits goes through the end of August of 2026. If she did not meet eligibility requirements on the annual September reboot that happened in the SEP program, then she would lose coverage at the end of August. Dan could go, oh, now I have an SOE to add Susan back to my PEB retiree coverage as a dependent.
So last year, there were several school employees that kind of got caught in that bind of they hit those hour limits right around the end of May. So they were, at that time, they were forced to go into the SEP for their coverage. And then they had to, at the end of August, they had to go back into the PEB because that calendar year was expired. Is this going to address some of, because one of their concerns was specifically how much paperwork that would involve on their part, where they would have to do all of that themselves, make those conversions from the PEB to the SEP, and then in August, they would have to do it from the SEP to the PEB. Is that going to address that so that they would be partially removed from that equation? It would be done for them by the automatic enrollment?
I was with you until the very end of your question. Okay. It does not change anything about when, in this instance, like bringing Susan back on as a dependent. There would still need to be the triggering by Dan, the subscriber, to add Susan back on. What this does do is it eliminates the front end. The history of this is everybody used to have to turn in forms all the time, no matter what. And the journey back in 2022 was to say, okay, well, here at the Healthcare Authority, we know who's a PEB retiree, we know who's a PEB employee, we see the connection. We're not going, the board, we recommended the board adopt it. We're not going to eviscerate and eliminate future retiree coverage because you forgot to turn in a deferral form when we see you in the system already. And then as we were exploring that, we were seeing this eligibility that was happening with PEB, rather than understanding the implications of Medicare preventing incentives. You can't incentivize people waiving employer coverage to come into Medicare. That's what led us to go, okay, well, let's also reduce the paperwork when it's happening on the PEB side. When somebody's getting, because we also see that here at the Healthcare Authority. You see all of those people like, we don't want to eliminate their access to the future retiree coverage just because we can see them, but they didn't turn in a piece of paper that says, I'm going on to coverage in your employee part of your portfolio. This is actually taking that concept and going one step further to go. And that includes dependents for the same reason that we ran into the challenge last year of school employees who hit eligibility late in the year. And we go, well, we can't incentivize them waiving coverage. The process can't be that they're allowed to waive PEB and stay on PEB. That would run afoul of Medicare rules. We realized as we were further exploring all this, we're like, that goes for the dependents that are in PEB retiree coverage too. So it reduces the paperwork on the front end so that you don't lose the ability to come back into PEB, but it doesn't change anything about the paperwork that's necessary to actually enroll when you fall off of PEB eligibility.
So they would still have to do that in August, and that piece would have to be done by that person.
Correct.
Next question, if Susan was not going to work for a school, but was going to work for ABC company, she could waive the insurance, right? If eligible, I mean, I guess, is this because we want the employer contribution?
I think the root of the problem here is we have actual knowledge of the individual having eligibility in our portfolio. We don't know if Susan goes and works for company ABC and we're incentivizing, we don't have actual knowledge or awareness of the potential Medicare incentive for waiving employer sponsored coverage. Company ABC shouldn't be allowed to allow their employee to waive coverage to come over to PEB retiree coverage. But we don't have knowledge of that, awareness of that. The real problem, part of the real problem here is we have actual knowledge that Susan is eligible for an employer-sponsored benefit that we also administer with the other hand. And so our actual knowledge, we have to address that somehow. And that was kind of, that's the root.
And I'm going ahead to the next slide, I apologize for that, but where it talks about why she can't stay enrolled. It says about federal rules prevent employers from not offering. Well, there's a difference between not offering, not accepting. So I don't know if that's just wording. And then it goes on and said, well, she can't waive it because then because the employer plan needs to, the feds want the employer plan to be the primary, not Medicare. I understand that. What threw me off was wording about not offering. And so we've offered, what we said is you can't waive. Not, thank you.
Well, let's have Stella go on to the slide and then we'll keep going questions and see. Yeah, why don't you just do slide 8?
Okay, so going back to Harry's question, why can't Susan stay enrolled in a PEB Medicare plan and waive set medical? So like I mentioned earlier, Medicare rules require employers to offer employees over the age of 65 the same benefits under the plan and the same conditions as any other employee under age 65. And the federal rules prevent employers from not offering group health plan coverage to an actively working Medicare beneficiary who otherwise meets the eligibility requirements. So Susan cannot waive set medical and stay enrolled in the PEB Medicare plan because her set medical will be the primary payer for medical services under Medicare secondary payer rules.
And Stella, I want to highlight that the not, like 6 words into Stella's answer, federal rules prevent employers from not offering group health insurance. That was another question that had come up last year, is could the legislature go and say, we're going to carve out eligibility from SEB and say, these individuals, once they, set up some sort of statute that says if you're once you reach 630 hours, you get the employer contribution from SEB, unless you're a PEB retiree currently actively enrolled. They can't set that framework up because federal laws and rules prevent the employer from not offering the SEB plan in this instance that we're talking about. Because several people asked that question, like, could you just carve them out from SEB eligibility? And the answer is no, because the federal rules and statute, I'm not sure if it's statute or rule here, prevent an employer from such eligibility carved out and basically frame shifting to Medicare. But the first couple of times I read the sentence, I kept not reading for it not, and it's an important not to read.
And I don't know why Susan would want to be enrolled, why, it's just, not everybody's employer plan is as generous as ours, so there could be a situation where it's better to be in Medicare than in employer's plan.
Well, Harry, I think what we've heard from school employees, because I think this is in retiree substitute, PEB retirees who are substituting in the SEB program, because I do think, I want to make sure people know that we and my team appreciate this challenge that's happening here, especially if it's near the end of the school year and you finally reach 630 and then you're moving from your PEB Medicare plan to an active employee plan. Yep, you have a higher subsidy for sure from the employer medical contribution in SEB. But if you're only on that coverage for 2 or 3 months, you're moving over to a plan where you're restarting your deductible, depending on what your expenses were. It's different if your transition happens in January than it happens closer to August. And if you anticipate that you will come back the next year, what you think your eligibility might be in a future school year, it really is, there are challenges that individuals go, it would be easier to just stay on my Medicare plan, but unfortunately that's just not allowed.
That was exactly the catch-22 that the people that were in, and they didn't want to do it because of just exactly what you said, that it was all that paperwork involved. Here they were in, with maybe 30 days left in the school year, but they were now told you have to make that. And then in August, you're done with your SEB membership. Now you have to go back to PEB and Medicare. And that was where the real hang up was. But again, it doesn't look like there's anything that can be done from that end.
And anecdotally, we've heard that there are people in this situation who are very closely tracking their hours now, because in SEB, you cannot stack eligibility across district, which is different than in PEB for higher education. You actually combine hours across CTCs and 4-year institutions to stitch together eligibility. That concept doesn't exist in SEB. So if you could do 600 hours in Lake Washington School District as a substitute and 600 hours in Bellevue, and that's fine. You've worked well if that's under the eligibility for DRS purposes, but that's also the track. But you can continue to work if you're trying to supplement your income. You can work across multiple districts, and that hours don't stack under SEB, which there are 2 sides to every debate. That is also a debate that comes up in SEB, is whether one should be able to stack. But from the retiree perspective on that issue, there is a way to continue working, having additional income streams beyond DRS law pension, and avoid this in and out of PEB-SEB eligibility. But we know that there are people who are tracking it that way now, because those are the rules in which one can work through. But this policy resolution is about the dependents that are on PEB that we now have actual knowledge have eligibility elsewhere. But let's go back to the last part of your slide, Stella.
So what about Dan? So if Susan for this scenario, so he's not missing out. So if Susan has SEB benefits, can Dan defer PEB retiree insurance coverage and enroll in Susan's SEB health plan as a dependent? And yes, he can. He can defer PEB retiree insurance coverage, and we will let Dan know about his options so he can enroll in Susan's SEB medical, dental, and vision coverage. And when Susan's employment ends, or probably on her eligibility and for SEP benefits, and Dan can re-enroll in PEB retiree insurance coverage and add Susan back to his coverage as a dependent.
So to be clear, Dan and Susan would be in the driver's seat of what happens to Dan. But we want to make sure that we project that it's going to be a small enough number that we can do some more targeted personal outreach and say, hey, did you realize, take the subsidy that happens under the SEP employer medical contribution, where you are in the plan year, what you think Susan's future is in school district. And just don't forget at the end of the day, Dan, you could move over too. Let us know. Because if we don't do that, we know that there will be people who later come back and say, why didn't you tell me that I could have saved money if I switched over and then I just switched back? But everybody's situation and finances are so different. We think the best approach in this scenario is we feel we compelled to bring the board the piece about moving Susan off as a dependent because of Medicare rules, and then just doing an outreach to Dan to say, think about this piece of the puzzle and let us know what you want to do. John?
You and I and staff have had discussions, and Harry brought it up briefly, about private employers. How does this, or does it affect a spouse who's got a private Medicare Advantage plan that the employee is eligible for? And the employee is now a retiree and is eligible for PEB as well.
Can you walk through that scenario one more time?
Well, I'll just be totally frank. It's complicated.
I'm having trouble tracking the
It's
people.
complicated. Okay, so I retired from the University of Washington.
Okay.
And I'm at PEB eligible. My wife has been covered, and I've been covered under her Medicare Advantage plan from a private employer for the last 10 years. Now, if I want to take PEB now, can she retain her coverage under her plan, or does she have to take my PEB dependent coverage?
But you never have to enroll your spouse on your coverage in PEB. So there's always that discretion. I thought you were going to ask the opposite: is are you allowed to waive your PEB retirement?
That's what I was told I
and go over
can't.
to her account as a dependent. And I think the answer is, I'm not going to think. I'm going to ask Stella what the answer is, because she knows right now.
She should.
Could in this scenario, the retiree from UW defer their retiree coverage for PEB, hold their spot in line to come back at a later date, and go over to a private Medicare Advantage plan? I do not.
And I was
believe
told they
that's
can't.
eligible.
That is not a qualifying coverage under the PEB program to defer.
We can bring some more back.
No,
about
that's okay. I think I
But
understand
the
that.
answer is it's not a qualifying.
I just wanted to see
Yeah.
if this changed that rule.
It does not change that. Yeah, it does not change
And I'm
that.
sorry to personalize it.
No,
That's
we,
right up.
it's better to use
Yeah.
names to help
Yeah.
orient from. That's why we do scenarios with Dan's and Susan's and Jean's and Dave's and Scott
Yeah.
and all of that, because it just helps track and
So
personalize.
no Johnson Sheilas.
Right. We can do John and Sheila.
Oh, write it down.
No.
So this does not change, none of this changes the plans that are eligible to defer. PEB retiree coverage. It just auto disenrolls the current dependent who we now have actual knowledge has an employer contribution for SEP. And we picked the scenario and the example to be about substitutes because it's the obvious example that's the most bread and butter. But if somehow there was a part-time ecology worker and a retiree was counting fish and there was a seasonal job and they got PEB eligibility, the same rules apply. Because this is not SEP specific, but the most likely scenario is a substitute teacher, especially based on what we learned last year. But there are theoretically part-time positions in state agencies that might similarly result in eligibility.
Yeah, when we talked about the going back and forth, and Tom, you had mentioned kind of the paperwork and the need to do that. Is it a reasonable assumption to say that one of the benefits of benefits 24/7 or having it online is, would that information be saved so that you wouldn't have to start from zero again to submit your paperwork, or?
Theoretically, in the future, yes, we're not quite there yet,
Okay.
but yes, in the future, that would hopefully be a piece for people who are using the electronic version, that there might be able to be some pre-populated things.
Great.
Next slide, please. So we'll incorporate board's feedback in the proposed policy, and then members of the public and the stakeholders are welcome to submit feedback to HCA PEB set board policy feedback at hca.law.gov by April 21st, and we will bring the recommended proposed policy resolution back to the board for an action at the May board meeting. And that concludes my presentation.
I'll also add quickly, a few minutes ago during Tanya's presentation, I said, oh, we might have some rules that we need to bring back around wellness, depending on the timing of the closure. Stella and I were conferring during the break and don't believe that any of that, it's unlikely that any of that would happen. The earliest it would need to happen is next week. So to the extent I suggested we might bring more eligibility enrollment resolutions this year on wellness, I don't think that that's likely in the 25 board season.
Okay. No, we're going to have an update on benefits 24/7, and
Stella has another.
oh, I'm sorry, Stella.
She has a second presentation.
Sorry about that.
It's unusual for a staff member to have back-to-back presentations.
Yes.
I will say that, but yeah, on annotated page 4.
Oh, I see it.
I'll go ahead and start with the annual rulemaking briefing. For the record, my name is Stella, Policy and Rules Coordinator with the PEB Division. I'm going to go over high-level information on this year's rulemaking and highlight the most significant changes and rulemaking actions we are considering. No action is needed from the board for this briefing. Next slide, please. Here is the tentative rulemaking timeline. You will see there are quite a bit of activities in the next couple of months because we are separating the appeals chapters with the rest of the PEB rules for filing purposes. And so in April and May, we will file proposed amendments and distribute them for public comments. And in May and June, we will conduct public hearing and adopt final rule. On the slide, we say in August, the permanent appeals rule will be effective. I was contemplating on the filing deadline, so we're able to move the appeals rules and adopt them permanently in July instead, so we're a month ahead on that schedule. And for the rest of the PEB rules, it will be effective January 2026. Next slide, please. In addition to implement this year's board policy resolutions that the board adopted, the focus of this year's rulemaking is divided into 3 different areas. We're adding clarity to rules to better administer and manage PEB benefits. We're adding clarity to align with federal requirements, and we're making amendments within HCA authority. Next slide, please. Under administration and benefits management, we're amending the definition of waive to better convey an eligible employee may affirmatively decline enrollment in PEB medical because they are enrolled in Medicare Parts A and B as an primary coverage. The next sub-bullet is not part of the rule, but we're just trying to give you some clarity on what we mean by that. So the eligible employee cannot be enrolled in other Medicare coverage such as PEB retiree insurance coverage or the commercial Medicare Advantage plan. You get quite a lot of questions from subscribers regarding, hey, can I enroll in the 0 premium Medicare Advantage plan in the open market? The answer is no, they cannot. They cannot waive that commercial Medicare Advantage plan to and waive the employer benefits. And additionally, next slide, please.
Real quick, Stella, before we move on from that slide, I just want to highlight, so the original waiver rule just says the phrase enroll in Medicare. And that was created before Medicare Part D existed. And so in recent years, we've had this question where it says if I'm enrolled in Medicare, and that's why people have come and said, well, I'm enrolled in a Medicare Advantage plan. And doesn't that count? So the real clarity here is just clarifying that when we set Medicare in that rule, it means A and B. That's what it meant when it was created. It's just the world has evolved since then, and we're catching up on the clarity of the original intent of that rule by adding in that additional context of Medicare in this part of our rules being A and B only. So that's really what this is to catch up and acknowledge. We're like, why are people asking these questions all the time? We're like, oh, the genesis of this rule predates Part D existing. We just need to say the definition of Medicare here means A and B. So that's really what this is.
Next slide, please. And we're amending the waive rule to include when an employee will be automatically referred from PEB retiree insurance coverage. And we're amending WAC 18208, 196. That's the rule that describes what happens when a health plan becomes unavailable. We're including resolution PEB 2024-26 that addresses when a subscriber or the dependent lives outside of the United States permanently, they must be disenrolled by a Medicare Advantage prescription drug, or a Medicare Part D plan. Next slide, please. Under regulatory alignment, we are clarifying within our COBRA rules that an employee or the dependent may continue all of any combination of PEB, medical, dental, or vision for the maximum number of months as allowed under COBRA. And we're adding a new special open enrollment event when a subscriber or a subscriber dependent gains, loses, or has a change in their Medicare low-income subsidy eligibility. Medicare low-income subsidy, also known as the Extra Help Program, is a Medicare program that helps individuals with limited income and resources to pay for their Medicare Part B premiums and out-of-pocket expenses such as deductibles and co-insurance. And this is new to us because we now have all these Medicare Advantage with prescription drug products and the UMP Classic Medicare with Part D plan. And so this new special open enrollment event would apply to our Medicare subscribers enrolled in PEB retiree insurance coverage, such as those enrolled in Kaiser or United Healthcare MAPD plan or UMP Classic Medicare with PDP plan. And this SOE allows a plan change within 3 full months when an individual gains, loses, or has a change in that LIS status. Next slide, please. Under amendments within HCA authority, we're making a technical correction to clarify any subscriber aggrieved by a decision made by the PEB program wellness incentive contracted vendor may appeal that decision to the PEB program. And we're amending to include that within the appeals rule that HCA may reject an appeal that the appellant fails to provide documentation or references of decisions previously rendered through the appeals process. Next slide, please. We're amending in the appeals rule that to state that the presiding officer will render a written initial order within 10 days after the presiding officer receives the content of the brief adjudicated proceeding file. Presentation. Any questions from the board? Thank you so much for your time.
Thank you,
Thanks,
Stella.
Thanks, Jill.
So now, we have a benefits 24/7 update. So Brett Mello, our Chief Information Officer from our Enterprise Technology Services Division, is bringing back the latest update on the benefits 24/7 system. And his materials are behind tab 8.
Morning, folks. Slide.
just to sort of bring us up to speed as to accomplishments that the team has made in improving our various issues towards our stabilization efforts. Since open enrollment, we have reduced our backlog or our depository that we have. In this particular case of account issues being those records that are held that aren't able to move from benefits 24/7 to pay one. From 7,500, actually, as of about 2 minutes ago, it's down to 2,182. So great progress on that. Our daily sync errors, basically that's because of those account issues, has gone from 2,750 down to, as of a few minutes ago, 781. So making great progress. We're picking up steam as we go forward. A good majority of priority bugs have been addressed. So 87% of them have been reduced. 75% of those being high priority bugs. And I know it sounds like I'm saying sort of the same thing. So we prioritize the priority ones. I know it sounds kind of weird, but it's a way for us to effectively parse through and prioritize those ones that are the most important to get addressed quicker than others and that are overall important. So great progress on all of that. I think what we found out yesterday, there was a meeting with the benefits administrators. Got a lot of positive feedback that they're recognizing the feeling changing. So that's a very good sign in our progress as well.
I'll just put a quick finer point because when you hear 223, you're like, wow, that's a lot of bug. A bug can be something as simple as don't pre-fill that radio button because it creates confusion, or that text above that what you have to input into benefits for 24/7 is confusing, to uploading of dependent verification documents doesn't work. Like a bug can be something big and it can be something small, and all of those are counted as a single bug, if you will. And that's why we have this additional high priority concept. I mean, a lot of people are very personal planning. You think about urgent and important grids, and you're like, is it urgent and important, or is it important but not urgent, and all of that? It's kind of the same concept. There's a subset of all bugs. All bugs have a prioritization to be solved at some point, but there are some bugs that are more important and urgent to solve than others. That's the high priority bugs. So, Skylar?
I have a question actually on the other side of things. Of sometimes it feels like you can't ever get out of prioritization because that's all that you can do. What is the strategy to look at the non-priority, and like how do you balance those two?
Right now, our issue is to get those top priority ones addressed. And as we start to get through those, we'll start to incorporate the lower priority ones. So we're looking at getting to a point of stabilization here in the next several months, meaning those high priority bugs are well down to a very manageable, because there's always going to be something. And so we've created some thresholds that we think would be expected. And then once you're down there, now you're kind of dealing with everything and addressing the low priority ones as well as the high priority ones. So we will expect to equalize, for lack of a better term, here by the end of May.
And some of the lower priority bugs that are language oriented, there is a refresh and preparation for open enrollment every year, and some of that gets caught up as the most active time when people are coming into the system and engaging. Is some of that gets cleaned up, if you will, or are lessons learned as additional things are being addressed in language on the page. So that's another way that some of the lower priorities that might never rise to a high, urgent, and important ultimately get resolved as part of the cyclical OE prep.
And just to go back to give you a little bit so you can get your honorary IT badge to wear. When Dave was talking about all of the bugs that we have, whatever they are, whatever their priority is, basically a difference between them is level of effort to resolve. Right? Some are very, very easy. We've addressed a lot of those that were very complex. And we're getting down to bugs that are really, really easy to turn over. They're not major, they're easy to fix. And so that's also helping us pick up steam to get us beyond the threshold when these are issues. So wanted to also update you on our plans for staffing. We have a new software test engineer that's been hired, and he's onboarding very, very quickly. So this is the person that, as we fix the solutions, we want to make sure that before we put them in production, that nothing hit surprise. And so it's a key role for us. And so we have a gentleman that has started doing a phenomenal job on it. We are currently actively recruiting for a new role. I think I may have talked about this before. That's basically looking to focus on supporting the benefits 24/7 and bring them even more closely together. They're already working very, very well, but giving them a focused resource to help support them in their day-to-day operations. So we're actively recruiting for that. And then Dave will probably elaborate a little bit more on this, but as we plan ahead a little bit, depending on how the budgets pan out, on some additional resources that will help us continue to speed up. In this particular case, not necessarily going forward with having to address bugs, but there's going to be new features and functionalities that folks want. And we want to be able to turn those around effectively and quickly and continue to enhance and improve the platform. So these are some additional folks that will assist with that, hopefully in the near future.
So let me tie this together with Tanya's IT decision package and then some of the cognitive dissonance of adding staff while we're talking about state budget reductions. So there's multiple layers to think about here. So this 6 budgeted roles are 6 of the 9 that Tanya referenced are in the decision package that was both in Governor Inslee's proposed budget, not adjusted by any recommendations by Governor Ferguson, and in the Senate and House proposed budgets. So in a normal budget year, we'd be like, oh, okay, 9 FTEs are coming, but nothing's ever normal, so we're not, until it's all done, it's not really done. Those 9 FTEs have 6 IT positions, which are right here on this page, 2 in accounting to help with individual budgeting, budget account reconciliation issues, and 1 in the outreach and training unit, my division, that supports the PEB and SEB benefits administrators. So you go, it's April, budget hasn't been signed yet, you're kind of moving forward with this position. How do you do it? We assumed at the very beginning our decision package asked for 18 FTEs. We knew the answer wasn't going to be 18, but we also, given the challenges that were happening between the systems, we also didn't assume the answer was going to be 0. We didn't know what the answer would be. What I did is I held various positions strategically to be able to get ahead on a few positions. So the 2 that are here, 1 that's hired and 1 that's recruiting, were kind of deemed the most important of the 18 and most important of the 9 that were actually funded in the various budget proposals. And so I've used kind of internal budgeting variants to kind of pre-buy those FPs, but didn't want to go any further because it is such a dangerous budgetary challenge to go even further for the additional staff that we think are coming. We'll wait until the budget is signed and then we'll proceed with those. So there's a little bit of that. We've done that before in the program when something seems really close to coming. We knew the answer wasn't going to be 0 and we knew the answer wasn't going to be 18. So pick the most important position, began pre-buying them, if you will. And then you have to think about, well, how it's interesting, an interesting position to be in to see additional staffing investments by everyone in the budget process while also talking about staffing reductions or administrative cut reduction. I think that goes to show the importance of the challenges that we were facing with our IT systems, the fact that the state has not been able to make enough investments to really retire pay 1. And here we are with 2 systems that are 5 decades apart in age and having them work together for 790,000 covered lives between 2 programs. So there is, I think, this acknowledgement, what you're hearing is that acknowledgement of the importance of these IT systems to be able to get everything to work. And, it wouldn't be a scenario where, we get into the agency if the answer is 9 plus 9, and we go through staffing reductions for PEB and SEB money, and we go, oh, it's -3, so we're really only going to hire 6. We will add in the IT area. Those are separate equations. It's not a net. They're not going to net out. We're not going to use any investments that come from this and offset a cut elsewhere. We will invest exactly as we said we would for the decision package. So, yep, there is that strange phenomenon of talking about an investment in the middle of all these reduction conversations, but that is there and there is that commitment. So pleased about that because we do need to get these systems working. So we're doing a really good job so far.
Next slide. So just to wrap up, we will continue to help keep the focus with our resources on just stabilizing systems and not doing any more changes to the system. And as that last bullet talks about, for an additional, basically what that equates to is 2 months. So each sprint, that's a term that we use in software development, it's a period of time to fix and resolve, address, create things. And so each of our sprints is 2 weeks. So we're looking at 4 additional sprints, 2 months worth to get to our stabilization goals. And we'll be able to do that successfully. We're confident we'll be able to do that because we're going to maintain the moratorium. So lots of good stuff to come, but great progress being made today.
Thanks, Brent. Appreciate it. All right. I'd like to invite Beth Heston to come up. She's our procurement manager in the Employees and Retirees Benefit Division, and she's going to give us an overview of the annual plan renewal process for the PEB program. Her materials are behind. Thank you, Beth.
Good morning, Chair Linda Blatt, members of the board. For the record, my name is Beth Heston. I am the PEB procurement manager and one of the account managers for Kaiser Permanente in portfolio management and monitoring. And as you said this morning, we are doing an overview of the annual renewal process. Next slide. Here are the steps in the annual renewal process. We want to explain the process used to evaluate medical, dental, and vision benefits for our members and renew the contracts we hold with the carriers. The presentation may concentrate a bit on medical because they're the most complex plans we operate in many ways. And just a note, PEB staff generally live in the future by about 12 to 18 months. And so right now we are living in 2025, but we are thinking about 2026. And so when I reference dates, I will be using that sort of shorthand.
Living in the future is the new form of telework.
All right. Our first step in the annual renewal process is to evaluate and identify changes that our plans are going to be subject to in the next plan year. We then develop a work plan for the renewal process so that we have a timeline. Then we build a request for renewal document, and I'll go into more depth about each of these, but I wanted to give you the overview first. After the request for renewal, the RFR is created and individualized to each carrier. It's then released to the carriers, and the carriers are asked to formally respond. We then move into rate setting, and the contract rates and terms are negotiated with the fully insured carriers. Just wanted to remind you at the request of finance that we in HCA staff set the premiums for our UMP self-insured plans. So there's no negotiation that goes on with regions. Instead, we negotiate with fully insured plans. We then present those negotiated rates to the board for review and feedback, and ask the board to authorize the premiums. And then we, after board season is over and the votes are all taken, we finalize those contracts to capture all the changes in premium rates.
It's somewhat of a philosophical question, but just thinking about like if we're constantly renewing, it feels like you're never really opening up for a competitor to come in with a better option. Like how does that fit into the process at all?
Yep. So the renewal process that we do is the annual, and periodically the state will do a broader procurement that is opening up the entire portfolio for bid. The last procurement that was an open kind of portfolio bid was concentrated around the SEB program for launching that program in 2020. We did a procurement with fully insurance that went from 20, I think we started, we must have started at the beginning of 2018. So 2018 and 2019 was that procurement that resulted in the SEB portfolio. At that time, when we did that procurement, we did it in a way that any additional carriers at SEB could be leveraged over into the PEB program. I think this might have been before you joined the board, Mikhaila, but there was a period of at least 2 years after the SEB program launched where we did talk about possibly migrating additional plans into the PEB portfolio from the SEB portfolio. But ultimately, and I have to be careful because I can't remember how. I know we said this, but we went through executive sessions about the exact rates, and then ultimately we discussed publicly about how the rate structure just wasn't making a lot of sense for the board to authorize those additional plans over. And so after 2 years, there was no migrations there. There is no set specific timeline for when those larger market procurements are, if you will, but they are periodically. And so, it's certainly, given the budget environment, there might be some analysis and thoughts about when the next one could be. But it's, we do the annual renewal process so that we give assurances to the carriers who do win those procurements that there is at least this initial term and a potential longevity relationship, but it is also a responsibility to go out from time to time. So there'll be one in the future, not sure exactly when, but there's probably one, in the future that needs to do that. But we did try that with SEB, it just didn't pan out. I think opening up the entire portfolio again, now that SEB is stabilized to a degree, it's been around for 5 years. And there are certainly some dynamics, the original SEB procurement that would be there today. There were some carriers who were excluded because they left the individual market. If they left the individual market, they were barred from being able to compete in this portfolio. So there are some different dynamics that exist today than existed 6 years ago. So we might be getting to a point for a larger procurement.
Can I tag on to that question, which is, thanks, I'll bring that up. The current contract, say with one of the Kaisers, I don't know how many years ago, but when it went out for bid, or RFP, whatever the process was it intended that it stated it was going to be for a 3-year period with a definite number of renewals? I'm just curious what we signed up for originally in those that allowed us. I don't have a question, an issue with the renewals being kind of this indefinite. What I'm hearing is when we decide we're going to go out for a new contract, we will. Just trying to get a better understanding of typically what the term is. I mean, I'm used to it coming from a place where it was a 3-year time period or a 5-year. I think with Regents, it might be like a 10-year one. So I'm curious with the current fully insured medical, what did we sign up for originally?
Would you like me to answer that?
Well, I think the original, if you have to go into the full Wayback Machine for PEB, the original procurement, I'm not positive we actually have the original procurement documents, and it has an almost indefinite evergreen. That was before, I'm going to say the word modern procurement laws, even though modern is more than a decade, I think, in the making. And so that's a stretched use of the word modern in that instance. And so that ups the ante a little bit for, needing to go back out. Typically, though, our contracts, when you look across our entire portfolio, they will have something depending on the insurance product line. So when I say the entire portfolio, I'm talking everything from life and LTD to medical and dental will be somewhere, most contracts in an initial term of 3, 4, or 5 years, and then a set number of additional renewals that can happen which usually for most contracts ends up putting the maximum range somewhere in the 10 to 12 years. Except for life insurance, that one, because of the stability of life insurance, that one I think is actually 20 years. The UMP TPA Regents contract was a little bit more unique in to how that the finances of that contract were struck, and the initial term was actually 10 years with, I believe, 7 years of potential renewals, which got us to potentially 17 years. Part of that was locking in an admin rate for the entire decade that we're currently in, and some of the pluses and minuses that used to be previously negotiated in the annual process. So typically it's 3 to 5 years with plus 7-ish to 10 years is a typical answer. It's usually shorter on the medical and longer on the other insurance plans.
And so if I understand it correctly, and what actually happened last year, I think, is that some fully insured that's on the SEB side could come over and say, we'd like to present a proposal to the PEB side. And the PEB, because of the way it was set up, we were gonna take advantage of that.
Yep.
Okay, great, thank you.
Next slide, please. All right, so why do we do an annual renewal cycle? Because HCA is funded by a yearly budget controlled by the legislature, and because the board authorizes all premiums for fully insured plans, PEBB formally renews each year, whether benefits or premiums change or not. The key here is that legislature sets our budget, and then you as a board vote to authorize the premium. If the state budget doesn't pass or the board doesn't vote to authorize, then HCA can't offer those carriers health plans to employees or retirees.
Real quick, I just highlight that Sharon joined the meeting a few minutes ago. And the finer point of the way I always say what Beth just said is, remember, no plans exist for 2026 until you authorize them. They have to be funded by the legislature and authorized by the board. The slate is blank until you act.
Next slide. So my, as I said, my team is the portfolio management and monitoring team. And so we are tasked with evaluating the portfolio each year. Next slide. We start with uniform medical plan. We have, of course, our third-party administrator with Regents Blue Shield, and we diligently evaluate the authorizing environment, the historical data about UMP claims utilization, adjustments to known or projected, adjustments related to known or projected changes that result in cost savings to the plan, covered population demographics, economic trends. That's where we start. And because UMP has the highest enrollment, that then drives a number of the other pushes behind what we do. And PEBB Finance handles the rate setting process, and they'll present to you, I believe, next month or in June about the rate setting process. So I'm not going to undertake that here. Next slide.
So where it says the historical UMP claims data and utilization, so do you evaluate the way that UMP reimburses providers? Is that part of that claims data? So people submit their claims to UMP, and then Regents, in this case, is the evaluator, and then how quickly the turnaround is to come back. Or reimburse.
Yeah, Tanya, I think I can do it, but you're here.
I told you I'd be in the back.
That was a promise to me earlier.
Got you back. So yes, Tom, when we are setting rates, so for 2026, what we will do is we will look at historical experience from 2024. So individual claim line by claim line, what actually happened in 2024 as our baseline experience. But then what we do is we look at what's happening in 25 to date. And what do we need to apply to that data to get us through to a projected end of 26? So we'll apply 2 layers of trend. So it's what will get us through the rest of this current year that we're in, and then what will get us to 26. So on top of that baseline experience, we know that provider negotiations have happened that would not be included in that base experience. We make adjustments for that. We also know that certain drugs are coming out with maybe biosimilars. We make specific adjustments for that. We know we might be getting different pharmacy rebates. We make adjustments for that. We know our administrative budget is getting reduced. We will make an adjustment for that. So what we'll do is we'll use 24 as the baseline. We'll project everything we know to date to get us through 25 and then make additional adjustments to get us through the end of the projected 2026 plan year. Does that answer your question?
Well, and those assumptions relate to both, we always say utilization and unit costs. And the way to think of that is how many widgets are being bought and what is the cost of each of those widgets in healthcare. It's like, oh, there's a lot more colonoscopies happening. So we need an upward adjustment for the rest of for 2026 that we think there's gonna be more colonoscopies for whatever reason, because that's what we're seeing as a trend so far in 2025. But we also know that colonoscopies now cost more, and I'm just using that as a hypothetical example. It's when we say utilization, we're generally, I think, usually meaning like the number of colonoscopies, my hypothetical example. But we're also, as Tanya said, we know the provider negotiations are going on, and so that the unit cost of those individual services might also be going up. One of the big challenges that we always have, though, is we are doing all of this, provider negotiations are happening year round. And so, there will be things that happen after rates are set, but before plan year 26 officially starts for negotiations that are happening in Q3, Q4. And we have to make some sort of educated assumptions and guesses related to that to be able to account for some of those costs so that we're not having as much fluctuation year over year. But if there is something that we learn after the fact, it just gets rolled into the next year baseline.
And we're self-insured, so we take on that risk of the unknown. And that's why you'll see then me back here next year saying, oh, we need to adjust the second year's funding rate again.
Okay. All right, thank you. And just as a reminder, we've already said this a number of times, but all of our carriers are on annual renewal cycles. Some of them may not be, the renewal may not have to do with rates. Because dental and vision carrier rates are more stable and don't fluctuate so much, we can actually get them onto 2 or 3 year rate guarantees. And so the only thing being renewed is the contract. We may have language that we want to add to the contract or small changes that need to be made, but that goes on yearly as well. And of course, our covered populations, we have, the active employees in the SEB and the PEB programs, and then we have the retirees in the PEB program. Next slide. We have a number of different types of medical plans. Just to remind everyone, we have different carriers. We also have different kinds of plans. We have high deductible plans like our CDHP and HDHP. We also have low deductible plans like the classic plans in our portfolio. We offer different types of networks, health maintenance organization, which is a narrower network. You have to stay in the network. Then we have preferred provider organizations where the network is a bit wider, and the relationship with the provider is governed by contracting. For retirees, we have different types of plan. We have Medicare with Part D drug plan in uniform. We have a Medicare Advantage with Part D for our Kaiser retirees. And then we even have the Medicare supplement plan or Medigap plan. So how do we know where to start when we evaluate the portfolio? Next slide. Well, we start by reviewing state and federal mandates. We evaluate mandated changes to our portfolio and figure out which carriers' plans are impacted by mandates. For instance, the IRS sets some rules around people's health savings accounts. And those can affect our high deductible plans because those plans are qualified for health savings account. So if there's a federal change, we would have to look at the CDHPs and the HDHPs. What plans are excluded from the mandate? You know, obviously, if it's an IRS rule, it doesn't affect the rest of the portfolio, only those high deductible plans. Does the mandate directly address member cost shares? That's an important question. Is it going to make them have to pay more, or is it perhaps going to lower their cost by moving something into a preventive category? And are the impacted carriers in alignment with one another in their interpretation of the mandate? If the carriers aren't aligned, HCA may reach out to our legal department, our rules and compliance folks, and ask for, you know, some sort of clarity that we can then discuss with the carriers about the mandate and see if we can get alignment amongst them. We also, as you can see from Tanya coming up to help, work closely with PEBB's finance team to evaluate the cost or saving impacts on members' premiums if the mandated changes are known to impact our carrier. Next slide.
One more piece about to highlight all this is the source of mandates. That's a very strong word at this point. To highlight the breadth of where that can come from. That can be an act by the Washington State Legislature. It could be by an act of Congress. It could be a rule by CMS. It could be a rule by the IRS. It could actually be a rule from the Department of Labor. There are some collateral effects that come over into employer-sponsored programs. So, but I wanted to really highlight that those mandates can come not just from Congress or the legislature, but also from CMS. That's an important piece. And an example that was in the news recently that could have impacted our plan because of the decision that was made not was when the former administration was leaving, there was a CMS rule that was proposed and needed finalization related to possible weight loss drug coverage in Medicare plans. And then an announcement recently in the last week that that was not going to be finalized. But that is an example of a CMS rule that could have been something that changed and created a forced scenario of these types of drugs must be covered within the Medicare space. So just highlighting how all of we have to check a variety of different places, not just RCW or the United States Code. It's also CMS, IRS, DOL. Those are kind of the trilogy of federal agencies that these programs have.
Okay. We also then evaluate the benefits themselves. So we undertake a review of existing benefits to see, are they working well? How much are they costing, or are they saving us money? And that's part of the benefit planning cycle that John Parton spoke to you about earlier in the year. We have a responsibility to compare our existing benefits to collective bargaining agreements. And the PEBB finance team, once again, they are the ones that monitor the CBAs and help us with the budgeting as well as the evaluation process. And then we have changes that if we know about them at the time we're doing the evaluation, come from the carrier. And so we will evaluate how those changes impact already existing benefits and whether the changes are related to the carrier's book of business. Elliot?
Yeah, I did look up book of business, but can you give me an example of that occurring?
Let's see if I can think of one from recently. A couple years ago, Kaiser Permanente introduced a at-home healthcare for folks who had recent procedures. And they wanted to move them out of hospitals to save money, to prevent potential infections that sort of thing. They wanted to move them home sooner and have, sort of bring the doctor to them. And that was a book of business change that they proposed to us. And we accepted it because we thought the outcomes would be good, and it could lower costs. It ran for a couple of years. The decision was made to stop using that program. That would be a book of business change.
And just to remind, so we think of our portfolio as our book of business, but from the carrier's perspective, you know, Kaiser has plans with King County, with the state of Washington, and with a number of individual employers. And so when we say book of business change, we're asking the Kaiser in this example to say, is this something that you're uniformly proposing across all of your employers? In fact, sometimes they're saying, we are making this change. We're no longer doing business as usual. We're making X change, and we are doing that for everyone. And there is no discretion. Really, the choice then down to the board is, are we going to accept the plan at all? But there are times where they are proposing something across their book of business, and they really are tailoring it based on each employer's decision. And other times where they're making something across their entire portfolio, across all employers, and they're saying, we are implementing this way. So think of book of business as their entire offerings to all employers. Sort of like what's their portfolio of offerings across their entire market. That's the way we do that too.
Yes, and we do have a pretty customized plan. So they've adjusted for us and the things that we need, and sometimes we return the favor. Next slide. So we've evaluated our benefits, we've evaluated our mandates. We're ready to do the renewal. And so we need a vehicle for these changes. Ouch, sorry, I've hit myself. We need a vehicle for these changes, and we've invented this request for renewal. You won't see this outside of PEB. Most people would call it a request for proposal. But as Dave explained, we have a big request for proposal, so we invented this term. Next slide. This is the process. First of all, we develop a work plan. Like every project, even ones that happen every year, timing is everything. So PEBB starts with a work plan, and we have all known tasks and all known dates for the deliverables that we use internally. And we do that so that shared services, and shared services is an agency term. It just means the other divisions in the agency that help us. So finance is a shared service. ETS, Enterprise Technology Services, is a shared service. We want to be mindful of their work plans and their workflow. And so we build our work plan so that we have the shared awareness of each other's other deadlines. And this work plan enables everyone to do their best work in a timely manner and know when everything is due. The renewal cycle timeline starts usually in January. So in January of 2025, we're working towards January of 2026 go live. So it goes from January through December and ends sort of at open enrollment at the beginning of December. Then the new plan starts January 1st, 2026, and we start the next year. Next slide, please. There are two teams in portfolio management. One of them is the Uniform Medical Plan team, and the other is the fully insured team. I'm a member of the fully insured team because I'm on the Kaiser account. The Uniform Medical team writes their own documents. They're usually work orders. So if we have changes that are brought about by those mandates, they put those in work orders to regions. We, in the meantime, build a request for renewal document of 20 to 30 pages that we're going to send to our carriers. That document that we release usually at the end of February, beginning of March, is a legally binding document. It binds HCA and it binds the carrier. It's a formal request for renewal, but as I said, we've chosen to call it something different. And that's what we release. Next slide. So once that's released, we move to the next phase, and that is carrier proposals and negotiations. Next slide. This is when the carriers answer us. Carrier proposals, they respond formally to us, and they're returned in mid-April, but the bid forms come in the 1st of May. And as we said, they're legally binding, so we include several mandatory annual attestations in that document. Probably the most important of those is the certifications and insurances. This is a binding attestation that the carrier is willing and able to contract with the state. They still have a license, they're still in good standing with the Office of the Insurance Commissioner, and they have network adequacy, et cetera, et cetera. Okay. Then we also have a checklist that we create. This checklist is a closed document, and it asks the carrier specific questions and gives them space to answer those. And that's built in so that nothing is ambiguous or missed on either side. Then we have exhibits. Some of our exhibits are sent every year, like what's your service area? Which counties are you offering coverage in? We also, however, have exhibits that may change from year to year. Like this year, we have some new health equity language that's being introduced into the contracts. That is a new exhibit. But those will be returned to us along with the carrier checklist and the certifications and insurance to bind them. Next slide. Those also enable us to sort of pass information around internally a lot more smoothly. So at that point, fully insured negotiations begin. And as I said, because we set the rates for UMP, the real negotiations go on with the fully insured plans. And so it's a simple exchange process. They send us their initial bid with the request for renewal, and then PEBB Finance and PEBB Executive Management respond to those bids. There can be multiple rounds of bidding if we're far apart on what we think the prices should be, and certainly this board has been involved in some of those cases. And we will go back to them and ask them to sharpen their pencil. Next slide. Once negotiations are fairly complete, we bring that information to the board. And next slide, sorry. The first presentation is informational, and it's asking you to, or showing you the results of the negotiations and beginning the request for authorization of those rates. A procurement manager, usually me, will provide an overview of the changes. PEBB Finance will present final rates. The board asks questions or requests more information on any topics that they wish. And we also take public comment for the first time. Next slide. Then in July, we asked the board to take final action. At that point, PEBB Finance brings you the final premiums and calls for a board vote. The board votes to authorize those premium resolutions. If the vote is successful, then we move forward. Otherwise, there is kind of a scramble. But hopefully it goes successfully. Next slide. So here's the timeline in a graphic presentation. You see January evaluation goes on, January, February. The RFR goes out. In May, it comes back. In June, we bring it to the board and get feedback. In July, we publicly presented, and then the vote is taken.
I would be remiss if I didn't highlight what Beth described for the board actions were really the more public presentations. Don't forget, we have executive sessions that should start really next month and continue basically every meeting until the last meeting, where we talk about some of the incremental finance from the financial perspective, some of those incremental changes. So there are additional parts of our board meetings that are designed before we get to the public space to discuss some of the potential impacts as we are negotiating. A reminder and for the public that it's not just a flop out at the end. It is from their perspective, but for the board, there are engagements and executive sessions to understand kind of your general reaction to the negotiation process that the agency is doing on behalf of the state, that you ultimately are the recipients for premium to authorize, but we kind of gauge your reactions as we're making decisions to the negotiation. Elliot?
Yeah, I think I'd be remiss if I didn't bring up the fact that a couple of years ago, the board was very reluctant to approve of certain rates. And it didn't even occur to me what would happen if we didn't approve the rates. It was, at least to me, a shock. I can't speak for other people. Can you at least mention that scenario?
Yeah, I think the important thing to remember is, I might have said it in passing a couple of slides ago, is right now, nothing exists for 2026. Nothing exists unless the legislature provides the funding and the board authorizes that plan's premiums. So every year, we basically start anew. And unless something is affirmatively approved, it does not exist. So let's do a specific example of that. Whenever we bring you UMP premiums, we know that it seems very clear from the budget that we're not going to be bringing you a UMP plus premium. That's actually the way for that plan to be retired. You don't have to make an affirmative vote to close that plan. We just won't bring you a rate for you to approve to authorize the plan. So if you extrapolate that to anything else, when we bring you a final suite of benefits or plans and rates, let's say we bring a carrier's portfolio and you are not happy with those rates, you can, if you don't authorize that carrier's rates or premiums, then that carrier doesn't exist in 2026. So just always think of it as it's a blank slate and you are building the portfolio every single year by affirmative votes.
And it's a slide 3 outlines that in my presentation.
But it's a good reminder to reinforce for everyone. I thought Gary's gets next and then we'll go to John.
Yeah, mentioning UMP plus, that within the SEB also? Just
It is, yes. Yes. The UMP portfolios are almost identical. UMP plus is actually identical between the two portfolios. John?
Beth, without getting into any specifics or minutia, can I ask what the talk in the street is about increased rates and premiums this coming year that you're hearing?
Yeah, we are at the moment in the lull. We have released the RFR. The first responses are due back next Friday, not tomorrow, but Friday the 18th. That is the outline of the plan. The bid rate forms that have the actual costing of the plan won't be in until May 1st. We have spoken to our carriers and told them that we are, they're aware of our budget crisis. We have spoken to them about maintaining status quo in rates and benefits, and we have not heard any pushback from them on that. And in fact, we have heard some talk about cost savings options. We don't know that we will entertain those. We'll have to see what they are.
I think Beth gave the optimistic view. I'm going to give the opposite view for a moment, just to prepare people and not have too much surprise. There are a couple of large provider negotiations that are later this year. There's one that a lot of people know of that's very prominent. With Kaiser Permanente and Providence. That is more on their PPO plan side, so that might influence more the PPO plans that are in SEB that weren't able to be migrated over into the PEB portfolio in the last couple of years. That's a provider negotiation a lot of people have their eyes on because the general common knowledge is that the last negotiations had a 10-year contract to Perry's point. And so a lot's happened since 2015, if you can think about that. And so there's been a lot of change in place. So there's a lot of interest in how that particular provider negotiation is going to ripple out. Most aren't as long as that, but there are quite a few provider negotiations, and how exactly carriers and providers will react to different parts of the legislative session is still a little bit of an unknown. A lot of what is driven for the fully insured plans is there's two sides of that equation. There's what they offer, and then there's what the employer medical contribution is set up for UMP. And so a big part of the negotiation process is the finalization of the UMP rate by the healthcare authority, and then the negotiation saying, and that means the EMC is X, take your bid rate, subtract X, there's your premium. Now let's sharpen our pencils. Is usually how that conversation goes. But there's a lot of places with a lot of upward pressure. So, we should hopefully be able to at least verbally give some sort of insights during the executive session in May about what kind of came across as the initial piece from the carriers. It won't be really extensive because it'll be pretty fresh in close proximity to the board meeting, but we can talk a little bit about where the starting point is, those negotiations. So that'll be a better answer to your question, John.
Yeah, along those lines, seemed to me last year we had the feds raised the CDHP. I don't know, max out of hope they won't do that this year. It hadn't been several years since they had been.
It had been, but part of what drives the IRS to change the minimum out-of-pocket maximum is inflation. And so there very well could be a change. If I remember correctly, we finally brought something to the board and asked for the authority to just chase the floor. And so we will tell you what the IRS tells us what it is, but it reduces a variable because sometimes when the IRS releases that in a proximity to the rest of our rate development was a little bit challenging. We're like, we'll tell you whenever they change the floor, but we have to, the decision was made by the board to say, yep, agency, make sure that the HSA qualified plan do the minimum that's necessary. So I'm not sure. I think originally we had projected there might be an off year. They didn't raise it every year. We thought there might be another off year, but inflation has been what it is, so it might go up. But we'll certainly tell you if that has to be raised, but we did it in a way that the board doesn't have to year over year vote to raise the deductible, but rather just have the agency change that.
And it doesn't usually come out to the end of the year. That's traditionally when they release.
Yes. What Elliot, the question you asked, I remember that incident, and I'm wondering really, when it gets down to a certain point, are we fairly in a bind, we as a board fairly in a bind because we hate what they are offering to us, but if we don't accept it, they can say, okay, we're out of here.
That's why we bring the board along the process, especially in executive session where we can share different pieces to try to prevent that as much as possible. And I think between PEB and SEB, there were attempts to lower rates, and in some somewhat successful in some instances, and not to everyone's desire, but at least some lowering. There was one point one year in the last 2 or 3 years where there was an initial rate, and then we came back publicly because the board pushed back, and there was a drop, and we had a longer board season, and that's why we have a little bit of space at the end in case that needs to happen. That's why we create all those extra, what end up hopefully being extra meetings, but it gives us the space to be able to have some more back and forth publicly, because there's a piece that the agency can do in negotiations, and then there's a part where you as a board can play a public role in encouraging a different result for the end point. But because at the end of the day, it's a blank slate for the next year until you authorize something, I absolutely can understand the characterization of it's take it or leave it, because it is at the end of the day, take it or leave it. And we don't have the ability to do a full public procurement determined by, under existing procurement laws that could rapidly pivot and introduce something new at the last minute. Michaela?
And I think it's related to what Tom and Elliot are talking about and kind of tied to my initial question at the beginning of the presentation. I'm gonna first say, like, I acknowledge my level of knowledge is like very superficial, and so the proposal is like maybe more to see if there's a future opportunity to have a learning moment to say, because like in my head right now, I'm like, this 2 options is what feels like it puts us in that bind where if we say no to one, then, because I remember, I think it was last summer where we had that discussion of, if we say no to Kaiser, then we're only leaving employees with one choice, and we don't want to do that. So the question around kind of opening it up for a full RFP is around, is there an opportunity to expand to 3 options so that it gives us an opportunity to actually say no if we don't like the premiums to one and still give employees the options to choose. I also realize that, you know, sometimes it's easy with the superficial knowledge to come up with an idea that has a lot of unintended consequences. So I think not necessarily for this meeting, but maybe to just understand like what's the pros and cons of a 2 option versus a 3 option.
Absolutely. And at that time, we can also start like, what does it look like to have a runway for a larger market procurement? Okay, we can definitely put that on the to-do list, but not today.
Yeah.
Like you said.
That'd be great. That'd be great.
All right. Any further questions for me? Thank you very much.
Thank you.
Thank you. Thanks, Beth. That was a great presentation. Appreciate it. So now we're coming to the time for public comment. So is there anyone on Zoom that would like to provide comments? Is there anyone on site that would like to provide comments?
I think we do have at least one
have
person
one.
online.
We do have one line online, okay. All right, so I don't need a list. We won't be looking for a list. And so we just have the ones, we just go ahead and open it.
Dina, we're gonna let the person, who is the person?
Yeah.
Okay, Fred Yancey.
Okay.
Fred's a pro at testifying
All
and
right.
public comment,
All
so
right, great.
we'll add his, he's already been added, he's turned on his camera, go ahead, Fred.
Okay, Fred.
Good mid-morning. My name is Fred Yancey. I work with the school retirees, school administrators. My concerns, and pardon my voice, it's of course a little hoarse this morning, is as you're looking at the annual renewal process, what sort of outreach activities do you perform to get feedback from users, both actives and retirees? What's working? What isn't working? What would they like to see in the program? I asked this question yesterday at another meeting, and the answer was an opportunity like this, which, as you can see, very few people take advantage of, and information you get from the board. But there was no mention about outreach to various focus groups, and I'd be interested to know if there are plans to do so. Thank you.
Fred, the way I think about that question is, I think historically over the years, there's a couple ways to think about that. Right now, we don't have as many people coming to public comment and board, but there absolutely has been in the past. The history is full of examples of things that have changed in the PEB and SEP portfolios, that the original genesis and germination of the idea started with public comment in board meetings, whether it was certain cancer treatments or the original recognition of domestic partners before same-sex domestic partners before the state had a registry, or there's examples throughout the program's history of the genesis here. We even had an individual last year, I believe, that has come and talked about the fertility benefits. I think people remember Erica. She's taken her story to the legislature. Unfortunately, that is a specific funding question that the legislature needs to ask. ask and answer, which is challenging with the budget environments, but there are pieces that come from public testimony. There is a level of engagement on benefit design. We have various stakeholder focus groups. I always summarize them as we have in no particular order: PEB benefits administrators, sub benefits administrators, PEB labor, sub labor, retiree organizations. We have at least those 5 core stakeholder groups that we talk with. And while we might not do a formal request about benefit designs, the inherent nature of those conversations often leads to, here are things we're hearing from our members. For example, the vision hardware benefit that increased to $200. That's something that came up as part of those stakeholder meetings. This hasn't come up for a while, but historically we would hear about gym memberships or silver sneakers within retirees. There are certain things that come up inherently in those meetings that kind of go into the benefit review cycle per se. But we haven't traditionally taken the annual renewal process itself to the stakeholder community. There is that public conversation that happens in June and July across the board meetings, but for the bigger changes within the system, I think the part of the purpose of those various focus groups is to have that type of insight come up there. So I guess I can, talk with the team about how we formalize that in those meetings, but part of what I anticipate coming from those focus group and stakeholder meetings is a two-way communication about here are things to improve. And we do make improvements based on those collaborations, and that's partly why we have those meetings. There's a variety of things that we have, we've looked at different rules or changed things or changed forms that have confused people or redone our retiree enrollment guide as a result of conversations in prior years. So those stakeholder groups are a place, even if we haven't necessarily formalized it as an agenda item. That is kind of, when we talk about ideas coming forward, that is one of them. So I can talk with people about how we more formalize that for folks. And I'm happy to talk with you more offline about that after the meeting too. We have any more? Okay. Apparently we do have a list.
We do have a list. All right. One more. Okay.
So Lisa, we will be letting you in and you'll have to you'll have to accept. I don't recognize your name, so if it's a bit jarring, it'll look like you're getting kicked out, but then you're not. There you are.
Yes.
Go ahead.
Hi, my name is Lisa Cook. I actually work at Shoreline School District as a substitute classified staff member. And I'm running into an issue that I don't know if anyone thought about it. The fact that I'm surprised by a 630-hour mark providing me insurance, which is the reason why I took the job, is that it had none because I have a good policy through my husband. But now I'm being forced in a surprise manner to make a decision. If I say no, my husband has to pay $50 more to keep me on his PEB benefits. And that's 2% of my income per year that I now have to put out to keep my job. And it just doesn't seem like it's a fair setup to be placed in this position. If I worked in multiple districts and didn't work up to 630 hours in each of those districts, it sounds like I would not hit this problem. But the fact that I'm committed to working in one school district in my community, it forces me to pay $600 a year to keep my benefits the same and stay in my job.
Lisa, can I just ask a clarification to make sure I understand the situation? Your husband is an active PEB employee at a state agency or higher education institution, is that right?
That is correct. He works for the University of Washington Medical Center.
Okay. I think I have a couple of questions, but we're not going to go over them in a public manner. I'm going to have, if it's okay, you said you're at the Shoreline School District. We'll look up your contact information and reach out to you so you don't have to say your phone number in a public manner just to get a few more clarifications. I have some questions about your scenario that we'll have the team look at, and we'll reach out to you to talk through the scenario of it.
I appreciate that because and this was out of the blue and I have to make a decision now whether, to take new benefits, which could change every year being a substitute. Being sick could throw me under the 630 hours. And then I'm in a tailspin of going back and forth between two insurances, which is also frustrating. So my inclination is to say no, but then that charges me $600 a year to keep my job that's what it feels like.
Yeah, the intersection of eligibility with the spousal surcharge. Couple of things to explore with you on that, but thank you for bringing that to the attention here, and we'll both work with you and then bring back some general information more about as we unravel the scenario.
I appreciate that and look forward to hearing from you.
Thank you, Lisa.
All right, thank you. Bye-bye.
So anyone else? All right. Well, that looks like we are at the end. So our next meeting is May 15th, 2025. We'll start at 9 a.m. and with the same format of attendance, either in person or via Zoom. And Dave, do you have any other comments you'd like to make before we adjourn?
I tried to do a preview of coming attractions for the May meeting. We'll update you with the bills that passed the legislature, because we do know that between now and then, the regular special session will end. I'm not going to say the corollary to the fact that I just emphasized regular special, but we will have April 27th will come and go before the next board meeting. There will be bills that are passed. We will talk about those bills and we will talk about wherever we are in the budget process. We'll also bring back the resolution that Stella, after sending it out for stakeholder reading, we will bring back the resolution that Stella presented today. We will continue to talk about benefits 24/7. Those are just a couple of things that I know that we'll talk about. So I just like to get a little bit of a break. And we will have our first executive session as it relates to at least verbally talking through some of the things we will have very recently on in the process.
Dave, will this be an all-day meeting or a half-day meeting?
Most of the rest of the meeting should still be half days.
Okay.
That's how you're saving money.
Yeah. Well.
And I might just add, I'm just thinking about this, excuse me, I keep coughing, but I may or may not be with you next time. It's likely I will be, but just to lay that out, and I just really want to express my appreciation and the opportunity to just actually sit with the PEB folks again. It was many years since I have, so thank you. But you, like I said, you may see me again. They are actively doing the recruitment and starting interviews.
Thanks for coming back.
Yeah. It's nice to be
Move to adjourn?
Oh, we don't.
Oh, that's right. We didn't. I didn't.
we don't really.
Adjourn.
Second,
Okay.
you just
I just adjourned.
Oh,
So,
Yeah, thank you.